My name is Melissa Budzinski with Gilda's Club Grand Rapids. I'm so grateful that all of you can join us today for this really important lecture. We hope that you're all well and safe. And if you're new to Gilda's Club or new to a cancer or grief journey, we would love to talk with you about our free cancer and grief support community. All you need to do is give us a call at 453-8300, and we can help you get connected, or look on our website, gildasclubgr.org. So today's lecture is titled Exploring Trauma of Cancer. It's brought to you today by the colorectal and related cancer groups here at Gilda's Club. We know that it is Colorectal Awareness Month, and we'll have a little PSA at the end from our wonderful volunteer, Alice Christensen, who helps with that group. Today we have two incredible guests with us. We have Dr. Jennifer Griggs, who comes to us from U of M, and she is a physician and professor of medicine and health management and policy at the university. She is an oncologist with a clinical management and policy. Oh, I said that already. I'm reading twice. We'll try that again. It's okay. She's an oncologist with clinical research focus on patient-clinician communication and quality of care. She is a staunch advocate for marginalized populations. Dr. Griggs is a program director of the Michigan Oncology Quality Consortium, a collaborative devoted to improving the quality of cancer care in the state of Michigan. She is also a personal leadership coach, helping people live and lead with joy and purpose. Welcome, Dr. Griggs. It's great to have you with us.
Thank you so much, and welcome everybody. It's nice to see you, and I'm really excited to be here with Dr. Porter tonight. We'll start with the first slide.
Okay, hang on one second, Dr. Griggs. I'm just going to introduce Dr. Porter, and then we'll get started with the slides. Yeah, that's all right. So then we also have Dr. Porter with us, and Dr. Porter is a psychologist and Director of Behavioral Oncology at the Cancer and Hematology Centers of West Michigan, based out of CHCWM in Muskegon and Lemmen-Holton Cancer Pavilion. It's nice to have you with us, Dr. Porter.
Thanks, Melissa.
So now we'll get started with Dr. Griggs, and I will share my screen, so bear with us as we do the technical dance here. And as I'm doing this, I'm remembering that I didn't mention that please hold your questions till after the lecture. And if you have questions, please put them in the chat, and then we'll make sure that we feed them to our guests. All right, it's all yours, Dr. Griggs.
All right, thank you. I'll have the next slide. And I thought we should start with what a definition of trauma is. It's common for us to think about physical trauma like a car accident or fractured limbs. But really the way I've always looked at trauma is it's an interruption of your life story. So you're going around your life and you live your life in chapters, like in a book. And this is the chapter that really took your life in a different direction. And we know that trauma affects the body, affects the mind, affects the spirit. It also affects our relationships and our communities. It really shakes us to the core. Next slide. So I thought I'd present 3 cases, and I wonder if you can ask yourself, do you see yourself in any of these people? What do you notice the 3 have in common? And how has their life story been changed by cancer? So we'll come back to those questions, or maybe we could even have people put things in the chat. But do you see yourself in the next case, for example? So Barb is a 56-year-old who underwent a colectomy for stage 3 colon cancer, and she's not a candidate for reversal of the colostomy, so she has a colostomy bag. She completed all of her treatment 2 years ago and still has regular doctor appointments, scans, and blood work. She dreads these visits and scans and can't sleep either before the day of the scans or for several days while waiting for the results. And she wonders if this will ever get better. When she walks into the doctor's office, she can smell and taste the chemotherapy she received as if it were yesterday. Do you see yourself in her? In the second slide, Jamal's a 42-year-old who has an ostomy after resection of stage 3 colon cancer. He's a second grade teacher. He's often distracted at work because he can't often get to a bathroom. It's really hard to find time when you're a second grade teacher. He worries about the sounds from the ostomy and curiosity of his students, what they think if they hear something or see something on his abdomen. He'd like to ask a teacher at another school in the district to go out on a date, but he doesn't know how to navigate disclosure of the ostomy and intimacy should the relationship progress. And the next case, please. You're doing great on the slides. Terry's 75 years old and was in excellent health before being diagnosed with colon cancer. His brother died of the same cancer at the age of 60. Terry, now retired, is ruminating about having had cancer. Some nights he can't sleep because he feels his heart racing in his chest and because of this fear he has. So before we go to the next case, just think about what do the cases have in common and how are their life stories interrupted? And in a bit, we'll get to things that folks can do, but I thought it would be useful for me as an oncologist to tell you what I've seen in my patients. Triggers for cancer-related post-traumatic syndrome, or sometimes called post-traumatic stress. The triggers can be anything from you were just diagnosed with a life-threatening illness, getting treatment, even when you know what's in your best interest, waiting for test results, which I teach my learners is a medical emergency to a patient, or learning the cancer's recurred, meaning it's come back in other parts of the body. So all of those can trigger this thing we call post-traumatic stress or post-traumatic syndrome specific to cancer. In the next slide, some of the symptoms are similar to those as depression, anxiety, phobias, and panic disorder. So while they feel sometimes like we make a distinction between them, a lot of the symptoms that I'll cover in just a second are common to these other diagnoses. Feeling defensive, irritable, or fearful, being unable to think clearly, having sleeping problems, that's problems falling asleep at night, waking up in the middle of the night, or staying asleep through the full night, avoiding other people, and loss of interest in life. The risk factors, and this, when we talk about risk factors, as I think you know, it doesn't mean if you have this, you're going to get it, or if you get it, you had this, right? These are just risk factors, like we talk about risk factors for anything. So history of trauma earlier in life, that can be a traumatic childhood, it could be a motor vehicle accident, it could be abandonment, early loss of a parent, lack of a strong support system or community, having a high level of stress in general or other mental health problems, such as anxiety or depression, and lacking training or strong role modeling for stress management. So you never got to see a parent manage stress well. Maybe folks in your family were avoidant and didn't talk about being stressed. If you come in with a high level of stress due to things like food insecurity or having lost a job or not sure where your next paycheck will be coming from. A lot of things we've seen during COVID, or a lot of disruption in your family like we've seen during COVID. I think even those of us who haven't had cancer yet can understand that these would be risk factors. Next slide. And then protective factors. I always like to operate from a non-deficit model. So not just what's sort of missing or wrong with people, but what strengths do they have? So some protective factors that can lower the risk, or as you'll hear from Dr. Porter in a minute, ways you can take these assets that you have and turn them towards healing, include strong social support, accurate information, and a supportive medical team. So that means you trust your medical team. They don't dismiss or invalidate your concerns, right? Like it was just cancer. It was you received the easiest chemotherapy. That's really hard for people to take. It's really invalidating. Next slide. And I'm going to turn it over now to Dr. Porter.
Thank you, Dr. Griggs. That was excellent and a great foundation for my part of the presentation. And I'm going to hopefully pick up the ball and carry it the rest of the way, focusing primarily on what can each individual do to lower the risk of trauma through medical experiences, as well as if you have been traumatized and it feels like the damage is done, what are some things that can be therapeutic and helpful. So I wanted to start, I asked the question and I kind of looked into the research as how do we define medical trauma? And so I've given you here the definition that is probably most comprehensive and most thorough. And I want to read it and just comment on it. This definition states that medical trauma is a type of trauma that occurs from direct contact with the medical setting, and it develops through a complex interaction between the patient, medical staff, medical environment, and the diagnostic and or procedural experience that can have powerful psychological impacts due to the patient's unique interpretation of the event. That's a pretty complex definition, but I think the value of that is it really demonstrates that unfortunately any healthcare related experience can be traumatic. It can be a conversation with a staff member or a physician. It can be undergoing a test or a procedure. It can be experiencing pain after a surgery. So really any experience in the healthcare system, unfortunately, can be traumatic for a person. And trauma is something that we can't gauge objectively or externally. So as a simple rule of thumb, if a person experiences an event as traumatic, it's traumatic. That's how straightforward it is. So the next question I kind of ask myself is, what are those qualities of experiences with the medical system that tend to lead to trauma? What distinguishes an experience in the medical system as non-harmful psychologically versus harmful or traumatic? And there are some factors that increase the likelihood that the experience is going to be traumatic. One factor is if the experience occurs in a unique or unfamiliar environment. And the reasoning there is when we're in an unfamiliar environment, let's imagine you're in a surgical center that you haven't been in before. Everything's unfamiliar and new. The walls, the smells, the staff. And that's sort of the opposite of comfort. When we're in an unfamiliar environment, we're not as relaxed, we're a little bit more tense. Our body's kind of primed to have a stronger emotional response. Additionally, because it's an environment that a person has not been in previously and is not associated with anything positive, if you have a difficult experience there, your mind says, okay, that surgical center, terrible pain after surgery, that site or that environment is directly related with just a single negative experience. And so that increases the likelihood of it being, a traumatic association. Another factor is when you receive news or information, from your medical team that's life-changing, it's more likely to be traumatizing. So when a person receives, let's say, medical information that they have an infection and they're going to need to be on an antibiotic for 2 weeks, but then it should clear up, that's not particularly life-changing. That doesn't tend to be traumatic. But unfortunately, when diagnosed with cancer, with a serious illness, those tend to be more life-changing, and the immediate reaction can be quite powerful. So those tend to be more traumatic conversations. Another factor is if significant physical pain is involved. Pain is a type of suffering. It's what most of us are most concerned about, with illness or specifically a cancer diagnosis. And so when pain and suffering is involved in an experience, we remember that. We don't remember the physical pain, but we remember the experience of the pain and suffering. And so that tends to cause a traumatic response. Similarly, if the experience involves a high level of anxiety or fear or autonomic arousal, which is, the kind of the restless physical response that comes with fear and anxiety, when we're in that state, it's almost like we're primed to have the experience be more impactful on us than when we're relaxed and calm. Another factor is if the individual has very little control over what's happening. So when we feel powerless, we feel helpless, experiences tend to be more traumatizing to us because we didn't have any control to prevent it, to take care of ourselves. We were sort of recipients of whatever happened rather than participants in what happened. And then finally, and if an experience involves feeling depersonalized, it tends to be more traumatic. And this means, feeling like you weren't really cared about as a person, you weren't treated as a person, with respect. So this can happen when, inadvertently staff and throughout the hospital maybe aren't real friendly, or a patient gets left in a room alone and feels like they've been forgotten about. Things like that can contribute to an experience really having a traumatic quality. So how is medical trauma different from other types of trauma? As Dr. Griggs mentions, there's lots of different types of trauma. We typically think of trauma in an automobile accident, or maybe trauma as a result of being a victim of a crime. And medical trauma is different in some key ways, in ways that makes it more complex and a little bit different to cope with. So one of the ways it's different is that medical trauma happens within the context of a patient-provider relationship. And what I mean there is, well, again, comparing it to other types of trauma, if you're in a car accident, there's really no relationship involved. Someone hit you, or you hit, ice and lost control of your car and you're hurt. There's not another person involved. With medical trauma, there's this relationship with someone who you trust and who is caring for you, and yet within the context of the events involved in that relationship, something very difficult, scary, painful happened. And so there's this complex interaction between this person's helping me, and yet I've been traumatized by an experience I had under this person's care. So that makes it complicated. Another difference is that medical trauma often happens at the hands of the system. And what I mean by that is sometimes experiences are traumatic because it's a series of little things, not one big thing. It's, as example I gave earlier, it's being left in a room for 30 minutes in a gown and cold and wondering, have they forgotten about me? It's a scheduler being rude upon a checkout, or making some comments, that's rude. The trauma can be just little things that all add up to make the experience that a person has traumatic. And then finally, medical trauma is often disenfranchised trauma. And what's meant by this term is that it's not trauma that's recognized by others as trauma. So if someone that you love is in an automobile accident, you ask about their injuries, but you probably also say, how are you doing since that accident? That must have been terrifying. That must have been so difficult. We recognize it as trauma. That tends to not be the case when people are traumatized by the medical system, because the medical system is helping. The surgery was to help, the chemotherapy was to help. And so family and friends may not recognize the experiences that a person has as traumatic. And in some cases, they may even say things that really invalidate the fact that it's traumatic, such as, well, but you need chemotherapy because it's going to make you better, but well, at least surgery was a success. So when you try to express how difficult the experience was, oftentimes it's invalidated by others. And then finally, and those of us in the healthcare system are a bit to blame for this, is that the reality is that the primary focus of healthcare tends to be on the physical body. So, let's say you're following up with your colorectal surgeon after surgery. The questions are mostly, how's your pain level? Are you moving your bowels? Are you, the focus is on physical well-being. Not very often, are the questions on, this was a big surgery to go through. How are you doing, moving forward from it? How are you doing managing your needs now? We tend to focus primarily on the physical body, which inadvertently sends a message that your emotional health isn't our priority, isn't what's important. So those are some ways that medical trauma is different and can be very challenging to cope with. So what can you do to lower your risk for medical trauma? And what I'm coming at here is, I'm hoping you haven't been traumatized yet, but you're thinking, because of my diagnosis, I guess it's possible that I could. What can you do proactively to lower your risk? One thing is to have a support person with you at most appointments or tests or procedures, because the reality is when something difficult happens, if we're alone, it's worse, right? It's scarier, it's more overwhelming, things just tend to be a lot harder when we're by ourselves when something bad happens. Whereas we have the security of a family member or a friend, the relationship, someone to process it with afterwards, that's helpful. The other thing that I would say is, make sure that you are, that you have good emotional processing practices in place, kind of in your life on a routine basis. So make sure you're doing things that are paying attention to your emotional needs and good for your emotional health now, every day, not just when something difficult happens. So this would be being part of a cancer support group, good for you on an ongoing basis. Participating in counseling, doing something that allows you to express your feelings and such as journaling or writing poetry or painting, some way of processing your emotions. Talking with family or a best friend or someone that you trust where you can share your story and share your experience. That's helpful. It also includes activities such as meditation or prayer or devotions. There are some really good apps available to help with this. So I've listed a couple of them on the screen. Headspace is a very good app. Calm, Tapping Solutions. So what I love about those is most of us have our phones with us at all times. So it's very easy if you are feeling really tense and anxious and need to relax, you can open an app and do a 5-minute meditation or a 10-minute meditation. It's at your fingertips. So those are things that you can do on an ongoing basis to really protect yourself from experiencing a traumatic medical experience. So what do the consequences, and Dr. Griggs covered this, so I don't need to spend much time on it, but it's restlessness, it's anxiety, it's fear, it's this uneasiness. Depression and loss of interest things are also common consequences of being traumatized. Difficulty sleeping, night terrors, bad dreams. The reality is our brains are still very active when we're asleep. And when you've experienced a traumatic event, a traumatic experience, our mind is wrestling with it. It takes a while to, really kind of come to terms with what happened and accept it. And in the process, our mind wrestles with it. And it often comes out in dreams, just distressing dreams, dreams that make it difficult for us to sleep. And then another factor is a strong desire to avoid things that remind you of the traumatic experience. So that might be avoiding seeing the surgeon that you had, or avoiding, driving by the hospital where the surgery took place, avoiding riding in the elevator that you rode up on the day that you got that bad news. So this strong desire to avoid these triggers. So if you have experienced some medical trauma, you've had a difficult experience, you're having some of these symptoms and feelings that Dr. Griggs and I have talked about, there are things that you can do, on your own to help yourself. The number one thing that I would recommend is really allowing some space for your feelings and your thoughts about the experience. Now, this isn't pleasant, it's not easy, and it's why a lot of us try to avoid thinking about something bad that happened, or try to just suppress the feelings related to it when they come up, because they're not pleasant. But research and experience shows that when we try to avoid feelings and thoughts, we try to change them, we try to repress them, they actually get worse. It's like an unruly child. When we try to say, be quiet, settle down, it makes them worse. And same thing with these emotions. And most importantly, it stalls the process of coping and kind of integrating this experience in a healthy way. So the best thing that I can tell you to do is to allow your mind to think about what happened, allow those feelings to come up, allow the tears to come out. It will eventually stop. But that process, as painful as it can be, is a healthy one, and it's one about acceptance that I went through something really difficult, and I'm okay now. I survived it. Other things that you can do is to practice relaxation exercises. So anxiety is a state when our autonomic nervous system is overly active. And so we're restless, we're edgy, our thoughts are racing, it's tough to concentrate. It's not an easy state to live in. And in fact, we're not designed to be there long term. It's a state that we're designed to be in for a short amount of time while we deal with some danger or threat, and then we calm back down. But certain circumstances turn this response on, and it just keeps going. So things that help to quiet down this response will be very helpful. So one technique is diaphragmatic breathing, which is a technique of doing some deep, slow breathing using your diaphragm muscle, which is under your ribs, to breathe. If you don't know what that is or haven't done it, you can Google it. There's lots of YouTube videos of people demonstrating it. So it's a powerful technique. It's easy, anybody can do it, and you can do it anywhere. You can do it while you're driving in the car. You can do it sitting in the doctor's office. You can do it laying in bed at night. But that's a very powerful technique. Guided meditation is another relaxation exercise that can be very effective. And guided meditation means you don't have to know what to do. You just have to listen and follow along to someone who's talking you through a process. And usually that process involves, excuse me, a little relaxing background music, a focus on muscle relaxation and deep breathing, and then some visualization of images and scenes that are calming and soothing and intended to bring about healing and relaxation. So another powerful type of self-care. And then finally, using calming self-talk, because with anxiety, it's anxiety is a state of being fearful and uneasy about what could happen, where we feel there's a danger, there's something bad is going to happen in the future. And so one skill that's very important is learning to focus on where you are now and reassure yourself that, okay, I'm just feeling very, very anxious, but I'm okay right now. Just need to take a couple of deep breaths. I'm safe. I'm okay right now. I'm just feeling anxious because, you know, this office is where I got that difficult news. You know, trying to, you know, kind of talk yourself through the anxiety and refocus on being okay in the moment. It's very important for managing anxiety. Another technique is actually to confront the feared stimuli, because avoidance makes anxiety worse. The more we avoid something, the more the anxiety grows, the more anxiety it provokes from us. So if it's a physical location, for example, a surgery center where you had your surgery, what you might do is say, all right, I'm going to get in the car today and I'm going to drive by that surgical center. And while I'm doing that, I'm going to use my deep breathing and just tell myself, okay, you're just feeling anxious, but you're okay. And you might do that a couple of times. And when that gets comfortable, you might decide, all right, what I'm going to do today is I'm going to go and I'm going to park my car in the parking lot at surgical center. I'm going to sit there for a couple minutes, you know, do that, use those same strategies. And when that becomes easier, you might then say, okay, I'm going to now set foot in the building. I'm just going to go in the lobby. I'm going to sit in the lobby for a few minutes. And what you're doing is you're changing the relationship between that, you know, that building and your emotions. And you're teaching yourself that this place isn't to be feared. It's just my mind associated it with a terrible experience. But I'm training my mind, you know, to have a different association with it. And then finally, you know, there are some medical treatments that can help with the effects of trauma. So individual counseling or psychotherapy can be very effective. There are specific therapies that have been designed to help with trauma, post-traumatic stress. So cognitive behavioral therapy, something called eye movement, desensitization and reprocessing, EMDR. But it's not too difficult to find, you know, professional counselors or therapists who have training in anxiety or post-traumatic stress, and that can be very helpful. Additionally, medications that manage the symptoms of depression and anxiety can be very effective. By calming down your physiology, by restoring your physiology to its normal state, it puts you in a much better position to cope with the stress, to do those things that are going to be helpful, as well as medication to help with sleep, because if you don't sleep, everything else is more difficult. We can't think as clearly. We don't have the coping resources to deal with, you know, anxiety and stress. And so sometimes it's necessary to use medications to get us sleeping better so that we can cope more effectively. And then participation in cancer support groups is a valuable and wonderful intervention as well.
Excellent. Thank you. Dr. Griggs, did you want to add anything?
No, I was just curious if the cases prompted anything, because we're not showing those slides again, but I wondered if anybody recognized some of those experiences. That's really great, Dr. Porter. I feel very relaxed just doing my deep breathing.
Oh, I had the chat up and then I lost it. Let me try that again. Okay, so this would be the time now if anyone has questions to answer either Dr. Griggs' question about recognizing yourself or seeing yourself in each of those scenarios, or if you have a specific question. I have a couple of comments here. That was interesting. You mentioned EMDR. Can you talk about that a little?
A little. That's about all I can talk about because I haven't been trained in EMDR, but I know a little bit about it. So it's an interesting treatment approach. It was initially developed for PTSD, which is post-traumatic stress disorder. And what it involves is a person who has been traumatized talks about their experience or tells their story of what the trauma was. And during that time, there's so the eye movement part is the person's usually wearing like a mask type headband that has some lights, and those lights will like move rhythmically while the person's talking. Another form of it is headphones with noises going back and forth. But what researchers have found is that process of telling their story with that eye movement somehow sort of reprograms the brain and changes the quality of that experience. And so it is, my understanding, perhaps the most effective treatment for post-traumatic stress disorder. Mm. And it's done over several sessions until the person's able to, really talk about and tell the story with minimal symptoms. So, and that takes, repeated episodes.
Okay, and I'm sorry if I missed it, but did you say that you have to find someone who is trained in EMDR?
It is a specific treatment. Yes, it's a formal training that's required, and so I think there's certification for it. So, yes. As far as resources, mental health resources in West Michigan area, Pine Rest is a great resource and a large provider. And so, for example, if you wanted to find someone who's certified in EMDR, you could probably go to their website. And I think that's a category, either trauma or EMDR. And you can search for individuals in West Michigan who have that certification or training.
Mm-hmm. Yes, and you can do that, I think, Michigan-wide on Psychology Today. And you can not only filter for EMDR, but you can filter for your type of insurance, if you want a male or a female, and what issues you want to address. And that's called just Psychology Today. And it can help you find a therapist for that. So great.
I can comment on Alice's message about the smell of the cancer center, the hand soap. So it's interesting. Smells can trigger some of the strongest memories of any of our five senses, and probably all of us have experienced that. Hopefully not in a traumatic way, but just we smell something that reminds us of early childhood or some memory. It's very powerful, and those are difficult associations to break. So I guess what I wanted to say about that is that's not something that a person is doing to themselves. They're not at a conscious level associating that smell with a bad memory or a bad experience. It's something that happens at a subverbal level. It's just a physiological association. It happens again. The same strategy of sort of coming more often. Using the hand soap outside of having a difficult experience might help to kind of dilute that association, but that is sort of part of the way the human brain works, and sometimes there's not a lot we can do to undo that once it's happened.
It's the oldest part of the brain that smells, so it's like this reptilian memory that we have for smells that are dangerous, and I hear that a lot too in my patients the smell of the clinic room. And I've had people say that what they would prefer in follow-up is to go to a different place.
Mhm.
And I understand that. And I also think there's some rituals of reincorporation, coming back to the same place and having things be less traumatic, just like we were hearing this sort of desensitization. And I think we're really thin on rituals in our culture. We don't have rites of passage that say you're re-entering life. Yes, you've been changed, but you can't cross a threshold and end up in the same room. But we also, there has been a change. And how do we reincorporate into our next normal? I have folks who've asked me not to say new normal, like something was wrong with them before. So next normal sounds more natural.
I like that, next normal. Yeah. We have had some of our members who say, this is not a cancer experience, this is a forced march.
Yes.
And so, yeah, because, I'm not, or a journey. She says, a journey is me getting on a cruise instead of, going to chemo. So we do have another question. I find more counseling. I find more counseling probably the more counseling I receive, the deeper trauma surfaces. How do I move ahead when so much trauma is in the past?
Sure. I think what you're saying here is in counseling, more of these traumas from your past seem to surface because, one mechanism for living with trauma and surviving it is to repress it and to find a way to, not think about it and, kind of push it down as far as possible. But then when in counseling, when you start talking about your life and your past, it comes up. My response there would be, while not easy or pleasant, it's healthy, for it to come up and for you to revisit it in the spirit of being able to kind of work through it and make some peace with the trauma that happened. I mean, that would be the goal. Certainly there's no guarantee that that's the outcome, but that would be the goal. Because when trauma or any, bad experience is repressed, like an infection that can't leave the body, it kind of festers and it creates problems. And it's probably the root of a lot of anxiety and sleep problems. So allowing it a path out in the long run is healthiest.
Great, thank you. We have Kevin who says, I love this information and found the suggestions for meditation very calming. I encourage this in others. Thank you both. Thank you, Kevin, for that.
Yeah.
I have two thoughts and two questions. And first, to Dr. Griggs, is that you mentioned in your slides feeling, or in somewhere in the slides, feeling disenfranchised or not heard by your medical team. Do you have some suggestions or some ways to help a patient navigate that if they're hearing those, oh, it's just cancer, if they're hearing those kinds of terms from their physician or medical team, what's a good way to go about managing that? Yeah.
Invalidation is such a problem in medicine. We're so happy to see somebody with a good prognosis, right? Or we don't know ourselves often how to cope with our own pain and loss. I would say a lot of people in the healing professions haven't had great experiences themselves. And so instead of validating and letting people feel seen for their loss, whether it's they now have an ostomy or they never can get a routine colonoscopy again, right? There's no such thing as actually any sort of routine test after cancer. Everything is fraught. And people will say, oh, it's no big deal. whether it's your friends or your medical team. And I think, there are nonviolent ways of communicating with people, even those in authority. But one option, of course, is changing to a different doctor. If this is a habitual problem, if it's episodic, practicing forgiveness, that person didn't mean to hurt you, it wasn't personal. But if it's continual and it's just not a good fit, you can always find another doctor. People feel like the doctor will be hurt or upset or angry, and it's your life. But I also think if you want to stay with that doctor, and if you want to be an effective partner in your care, that's saying, I observe that you say things like this to me a lot, and this is my reaction. So it's not, you're not blaming them or imputing motive. You're not saying you blow me off. That's about them. But if you can say, I notice a lot you are attempting to reassure me, and my reaction is actually to feel like I'm not as important. We see this with ductal carcinoma in situ a lot. DCIS is stage 0, and people are told it's a good kind of cancer. And some people, I'm sure, with colorectal and related cancers have also heard that with stage 1 disease, for example, or I've got great news for you, only 2 nodes were positive, that sort of thing. The intention is reassurance, but it's so misguided. And to be able to find people you can talk with about that. So maybe your doctor's not your only source. Somebody else in the medical team could be. Again, if it's habitual, making a switch. If you really feel courageous and you practice and you have somebody, with you who can say it went really well, noting your observation and your reaction, those are the 2 steps of nonviolent communication. And it's a way where we can get our needs met without cudgeling somebody else.
Yeah. Oh, that's beautiful. Very important. And I think coupling that with what we heard about how to help ourselves through our anxiety, this might be even facing one of those fears of talking to someone that we think has some power over us, and helping them get to a place of understanding us better, which then empowers us all over our lives, not just in the medical field, but it empowers us on so many levels.
It does. I did want to make a point about meditation. On a lot of the meditation apps, my app, it'll tell me how many days I've meditated in a row, and it calls it my streak. And that feels so competitive for meditation. And a lot of my coaching clients will say, I'm not very good at meditating, but that's not what it's about. Nobody's good at, you can't empty your mind or stop your thoughts. You just observe your thoughts and watch how you're talking to yourself. So I just see a lot of people struggle with meditation because they feel like they're not doing it right.
Yeah. And to start small and build a practice.
Yes.
We started in our house with 1 minute, watching a flame for 1 minute. And then we built up from there because that's where we were at. And that was okay.
And then celebrating, right? When you're done, you blow out the candle. That's celebration for the minute you did. Yeah.
Yeah. I will say that streak thing for me is a celebration because I feel like, yes, I did it. It keeps track for me, and it always is so helpful to me to know and it accumulates the time. I love that. Anyway.
Yeah, I love that too. That's how we grow habits.
Oh, so go ahead.
Well, that's how we grow habits, just by celebrating. So the celebration is that dopamine reward. So if you want to build a habit, start tiny and then celebrate after each one, no matter how little it is.
Yeah, that's great. Oh, I love that. And we have a note from Shay, says, I love that advice. It's definitely your right. And you have that right. Thank you, Dr. Griggs. It's not what you say, it is how you say it that sometimes really makes the difference. Yeah, that's beautiful, Shay. Thank you. So the second thing I was thinking, and we're kind of coming to a close here, but I was thinking if we could just speak to the physical response to trauma. Like we talked a lot about the emotional response to trauma, but it's my understanding that trauma moves from that emotional place into a physical place. And sometimes we are physically responding to something and maybe not even necessarily understanding it, but our survival system has come online and then our frontal cortex goes offline. So it's very difficult sometimes to think clearly in those moments. Can you speak to that, either one of you? Maybe Jeff, you want to start?
Sure, yeah. So anxiety is a very physiological response. As Dr. Griggs said, it's our survival mechanism, and it's a primitive part of the brain that controls that. And so the emotions are there. We feel the fear, the worry, but there are a host of physiological changes that happen at the same time. Our heart rate increases and our blood pressure increases, all to make us ready to act in some way physically. Our adrenal glands secrete more cortisol, which is a stress hormone. We produce more adrenaline, which gives us strength and energy, again, readiness to act. Our organs kind of go into a standby mode and push blood to the muscles in the brain because that's where it's needed. So when this happens in the short run, it's not too, it doesn't really cause problems. But when we get stuck there, what we end up with are muscle cramps and fatigue from all this tension, digestive issues and problems because our stomach and our intestines aren't in their normal mode. Increased cortisol and adrenaline is hard on the body, can cause nausea. So, those are a lot of the physiological symptoms that occur when you've experienced trauma or you're experiencing ongoing anxiety.
Great, thank you, Dr. Porter. Dr. Griggs, did you want to say anything about that?
There are some things to remember that can be done when you have that. Stress and fight or flight just jazzes up everything from deep breathing, like Dr. Porter was talking. There's also, if you're in extreme distress, of holding ice cubes in your hands, which it feels really unpleasant, but it can kick you out of that overdrive state. And that's used a lot for acute panic or dysregulation of emotions. But I couldn't agree more that the body responds like it's being chased by a saber-toothed tiger, which I now call a cyber-toothed tiger because it's usually an email that'll set me off.
Yes. Oh, I love that term.
Feel free to take it and have it.
Thank you. Yeah, and I want to say too that everything you both talked about, this meditation, this deep breathing, this exercise, this supportive place, talking about it, what that does is it reteaches our body to go to homeostasis. And so we have to reteach it that we're safe, reteach it that we're safe. And that some people feel like they might be mentally or emotionally unstable when this happens. But what I want to make sure everyone knows is there's no blame or shame about having trauma or anxiety about or from your cancer journey, experience, forced march. That this is a natural and normal response that our body has that is hyped up. And so teaching ourselves and being kind to ourselves in that way helps us to bring that down into homeostasis. So, yeah. Well, I think that kind of puts us right here, smack dab at the end. And this is wonderful. What an important and really wonderful conversation. That I really feel like we just started the conversation. There's so much more to talk about and to learn about and to know and to practice that we could just keep going. So grateful for you, Dr. Porter, and you, Dr. Griggs, for taking your time and gifting it to us and sharing your wisdom with us. And we hope to have you back sometime for sure.
Absolutely. It was a pleasure to be part of tonight's
It was
event.
great. Thank you
Yeah.
for having us.
Yeah.
Yes. And we're getting some thank yous. Oh, that's from you. You're so good. You can type and look at the camera at the same time. And I'm impressed. So we also want to have Alice is going to do a little PSA for the colorectal month. Alice, you want to take it over?
Sure. Again, thank you, Dr. Porter and Dr. Griggs, for joining us on one of our annual events to kick off March, the National Colorectal Cancer Awareness Month. So every year the topics are a little different. So thank you very, very much. So as I've said, March is Colorectal Cancer Awareness Month. And, it's not an old man's disease, what a lot of people think. It is the third most commonly diagnosed cancer in both men and women combined in the United States. Third most common. And it's the second leading cause of cancer deaths in both men and women combined in the US. So it's out there. It gets any age, any gender, any fitness level. And as many of us know who've been participating at Gilda's, the young onset colorectal cancer is on the rise. We have many young people younger than 50 joining our monthly meetings. So please spread the news, talk with people about Colorectal Cancer Awareness Month. It's not a sexy cancer. Nobody really wants to talk about it, but we need to talk about it. This Friday, March 4th, is Dress in Blue, and share with people why you're dressing in blue. I frequently tell people, talk to the people at the bank, talk to the people at the coffee shop, about March, Colorectal Cancer Awareness Month. We need to bring it into everyday conversation. So that's my PSA for March, Colorectal Cancer Awareness Month. Thank you all for joining us tonight.
Thank you, Alice. And thank you for being such a diligent volunteer for us and always wanting to get this message out there and be just continually doing that. So, all right. Well, that's all I have for tonight. We're so grateful for you joining us. Again, if you're new to a cancer or grief journey, or you're new to Gilda's Club and you want to get connected with our free cancer support community, we would love to talk with you. Give us a call at 453-8300 or look on our website, gildasclubgr.org.